Hello, my name is Philip Mies. I am Director of Rheumatology Research, Swedish Medical Center, and Clinical Professor at the University of Washington School of Medicine in Seattle, Washington. I'm here today to provide a Rheumatology Highlights Report regarding psoriatic arthritis abstracts presented at the American College of Rheumatology meeting in Washington, D.C. The first study I'd like to discuss is an epidemiology study known as the PREPARE trial. This was a study in which dermatologists in 34 clinics in Europe and North America referred more than 1,000 consecutive patients with plaque psoriasis for rheumatologic evaluation. 959 of these actually underwent the rheumatologic evaluation. This was a study that was sponsored by Pfizer, but was not a drug treatment trial. It was only to gain a sense of the nature of these patients and particularly whether they had evidence of psoriatic arthritis. In the first figure, the patient disposition slide, you can see the way in which the patients were programmed during the course of the study. You see that the dermatologist first evaluated them for psoriasis and then referred them on to a rheumatologist. In the first clinical assessment, the rheumatologist determined whether or not they thought they had psoriatic arthritis based on medical history and physical exam. Then laboratory tests were obtained, and the rheumatologist made a second judgment call about whether psoriatic arthritis was present. In a subset of patients, radiologic assessment was also done, and that allowed another opportunity for a diagnosis of psoriatic arthritis to be made or not. What you can see in Figure 2 is that in the group of 949 patients that completed and went all the way through the first clinical assessment, 30% of them were judged to have psoriatic arthritis. Of these, 40% had never been diagnosed with psoriatic arthritis before. The remaining 60% had had a previous diagnosis of psoriatic arthritis. Interestingly, there was a small group of patients, 47 of the 949, or 5%, that had a previous diagnosis of psoriatic arthritis, but this was not confirmed in the rheumatologic evaluation. So perhaps they had osteoarthritis or fibromyalgia or some other diagnosis. To me, the striking point is that 40% of the patients did not realize that they had psoriatic arthritis, so this was a new diagnosis for them. And it also confirmed the overall 30% figure that has been popping up in a number of the different epidemiologic studies of the percentage of PSA that's present in the psoriasis population. Some further data analysis was done, and that's shown in the next slide, Figures 3 and 4. And the take-home message here is that basically doing laboratory and doing X-ray did not actually add much more than the basic medical history and physical examination alone. In the case of laboratory, it only added 1% of the total 8 of 949 that were given a diagnosis of psoriatic arthritis, adding that to the medical history and physical exam, and in the case of X-ray, that only brought in another 5 patients. So all told, we are given some reassurance that our history and physical exam can really be quite accurate for us as rheumatologists in making the PSA diagnosis. Now I'd like to move on into a number of different treatment trials that were presented at the ACR meeting. And I'm starting with an anti-TNF medicine, Certolizumab, which was tested in psoriatic arthritis population. What was different about this trial compared to previous phase 3 anti-TNFs in PSA is that patients who had failed a previous TNF inhibitor could have come into this trial. And in fact, 20% of the population had an inadequate response to TNF therapy previously. What is shown on the left-hand side of the ACR20 responses here at week 12, the primary endpoint, was a result of ACR20 like we've seen in other phase 3 trials of anti-TNFs, in which up to 58% of patients achieved an ACR20 response in the overall group. If you look at the patients who had had prior TNF exposure and average out the two dose arms of the study, 200 Q2 or 400 Q4, you can see that a very similar percentage of patients achieved an ACR20 response as compared to no prior anti-TNF therapy. So in my mind, this teaches us two things. One is that one can successfully switch from one anti-TNF to another and still get a response, and that Certolizumab certainly works in this context. The other thing that was learned in this trial, which I'm not showing you data from, is the rapidity of action. And we saw that within a couple of weeks, patients were starting to have a response. In the next slide, I'm showing you ACR 50 and 70 responses, also stratified based on whether the patient had seen previous anti-TNF therapy, and you're seeing very robust ACR 50 and 70 responses regardless of whether the patient had been on TNF therapy before. In the next slide, I'm showing you data on enthesitis response using something called the Leeds Enthesitis Index, which evaluates 6 different sites, the lateral epicondyle, the medial condyle of the femur at the knee, and the Achilles tendon insertion. And what is shown here is that there was a statistically significant improvement in the Certolizumab-treated patients who had enthesitis. And then in the last slide of this set, I'm showing you the skin responses, PASI 75 response, and here you see a relatively rapid effect in the skin, and at the primary endpoint of 12 weeks, up to 60% of patients having a PASI 75 response, and as you go on out to 24 weeks, you're seeing responses up to the 70% plus range, so quite an effective agent on the psoriasis lesions of these psoriatic arthritis patients. Certolizumab is not yet approved for treatment of PSA, but is in the process of applying to the regulatory agencies for such approval. I should also mention that there were no new significant side effect issues other than what we've known about in rheumatoid arthritis that we're seeing. The last point I'd like to make from this Certolizumab program is that is a lesson about the X-ray evaluation. And that lesson is be careful about the imputation method that you use. What does that mean? Well, in any given trial, especially one with more than 400 patients, you're going to have a few patients that miss getting their second X-ray in the trial for one reason or another after baseline. And the question always is, how do you handle missing data? What was done here was that the FDA had actually asked the company to assign the worst possible sharp score value, which just doesn't make sense to those patients. So what was agreed to was that they would use whatever the worst sharp score in the trial was, And that was going to be what applied to the roughly 20 plus patients that had a missing X-ray. Unfortunately, it turned out that patient had a very high sharp score. They started with a high sharp score and they ended with an even higher sharp score. And so that ended up leading to the graph you see on the left, which is just doesn't make a lot of sense. And it ended up not showing statistical significant difference between Certolizumab treated and placebo treated patients. However, if you use more standard imputation methods, as on the right-hand side, either no imputation where you just drop those patients, or one where you take the median total sharp change of observed from baseline of observed patients, you can see very appropriate progression plots and statistically significant separation between Certolizumab treated and placebo treated patients. So we can gain some assurance when you use the standard methods that there can be X-ray inhibition of X-ray damage. Next, I'd like to speak to a relatively newer agent known as Ustekinumab, which is now out and approved for the treatment of psoriasis and is known by the name Stelara. This is a medicine that is given once you get to a standard dose once every 3 months subcutaneously. This drug inhibits IL-12 and IL-23, and it does so by targeting, as shown in this slide, the P40 subunit of these molecules. And this leads to a diminishment of both Th1 and Th17 cell proliferation and activation of cytokines in those different cellular lineages. What I'm showing you in the next slide is results of the second phase 3 trial with Ustekinumab. The first one was presented back at the EULAR meeting, and I showed you data on that in previous Cleveland Clinic presentations. In this trial, there were 312 patients who had inadequate response to either traditional oral DMARDs, such as methotrexate, or TNF inhibitors. And about 60% of the patients in this trial had been on TNF inhibitors previously. What you see here are the ACR 20, 50, and 70 responses of the overall group, with slightly over 40%, 43% actually, ACR 20 response, and then the ACR 20 and 70 responses that are shown here. Enthesitis was also improved. There was not a statistically significant improvement in dactylitis, but the study may not have been adequately powered to show that. In the next slide, I'm showing you just the data for the patients that had been on TNF therapy previously, and that the results are slightly less than what you saw on the previous slide, with 37 and 35% respectively in the 2 dose arms of the study achieving ACR 20 response, 15 and 16% respectively achieving ACR 50, and 5% achieving ACR 70 response. These are modest results, but it does separate from placebo, so suggests that in some of your patients that have failed anti-TNF therapy, this could be an option for them in terms of trying for treatment of psoriatic arthritis. Also shown here are the skin responses, and this agent has very effective results in the skin lesions of psoriasis. Safety data I'm not going through in detail, but there were no striking new adverse effect types of issues than what we have come to know about in the anti-TNF arena. Lastly, I want to comment about a drug known as Apremilast. This is not yet available to us commercially. It's something that we may have in the future. It's an oral medication, which is a phosphodiesterase E4 inhibitor. And what it does is it modulates, as shown in this build slide, the metabolism of cyclic AMP, increasing cyclic AMP in an immune cell, which then ultimately leads to the consequence of increasing certain anti-inflammatory mediators such as IL-10 and decreasing certain pro-inflammatory mediators as noted here, including TNF-alpha, IL-17, IL-23, and interferon gamma. This has had a study in psoriasis, psoriatic arthritis predominantly, and I'm showing you the results of something called the PALACE-1 trial, a phase 3 trial in which 20 milligrams twice a day or 30 milligrams twice a day were tested against placebo. And you see the ACR20 response at the primary endpoint of 16 weeks on the left in the overall group, with results of 40% achieving ACR20 with the 30 BID group. This is a modest effect. You see slightly better results, 43% in the biologic naive group, because patients that had been on anti-TNFs were allowed in this trial. There was a small percentage that were allowed. Then you see the effect of Apremilast plus DMARDs versus Apremilast monotherapy in the biologic naive patients. And what's fascinating is it appears that there may be a slightly greater ACR20 response in the Apremilast monotherapy group. Whether this is real or just due to small numbers is not entirely clear, and we'll have a better sense when we see other phase 3 trials rolling out. But in any case, it looks like it can be used as either monotherapy or with background methotrexate. Clearly, the results were not as good in the patients that had previously failed anti-TNF therapy. So this drug is, I think, going to be positioned somewhere earlier in the treatment paradigm in mild to moderate patients, and maybe, for example, after methotrexate use but before a biologic use. It also has some benefit for the psoriasis skin lesions. And best of all, it has a good safety profile with some nuisance side effects like diarrhea and nausea, but in many patients that tended to go away after maybe several weeks of use. And so it's something that was had quite a good safety profile. We'll be hearing about this more in the future. So with that, I'd like to close and just say that there were some very interesting new studies on PSA treatment as well as epidemiology presented at the ACR meeting. And I very much appreciate your listening in for this Rheumatology Highlights program.